Hello, everyone. I hope that you're doing well. I'm going to kind of review the electrical current that goes through the heart, if you will. So I did another video where we talked about the blood flow through the heart, where we were talking about pretty much the mechanical aspects of the heart, the movement, the contraction of the atria, the contraction of the ventricles, and so forth. But we do have to have an electrical current or an electrical circuit within the heart to help stimulate those contractual events. Uh, so I'm going to basically draw in the electrical current, talk about those items, and then I'll draw an ECG or just a one P QRS and P wave QRS complex followed by a T wave. We'll talk about those in reference to depolarization, repolarization, kind of what happens with that. Um, and I'll try to do a quick overview and not be terribly long-winded. So we'll go ahead and get right after it. So inside of the heart, remember we talked about the right side of the heart, because we're looking at this as it would be someone standing in front of us. Right side of the heart is, as far as the computer screen is concerned, on the left side. The left side of the heart is on the right. So this is our right heart. This is our left heart. So in the right atrium, you're going to find where our electrical impulse or electrical activity should begin. And I'm going to utilize yellow, and I may change colors here in just a moment, but nonetheless, there is a node inside of the right atrium that will generate the electrical impulse, the electrical stimulus for what's going to hopefully help cause the atria to contract in a coordinated event, subsequently followed by the ventricles contracting in a coordinated event, so that we can contract and squirt blood from the atria down to the ventricles, and then the blood can contract and squirt blood from the ventricles up into their respective circuits. If it's the right side, remember that's going into the pulmonary circuit. If it's the left side, it's going into the systemic circuit. So we have to have an electrical stimulus, and this is called the sinoatrial node or the SA node. Important to note that it fires at a rate of about 60 to 100 beats per minute. You'll also find coming off of that SA node that there's a Bachman's bundle or an intra-atrial tract that sends an electrical impulse over to the left atrium, so that the right atrium and the left atrium can ultimately kind of fire simultaneously with each other in in coordinated fashion. And then you're going to have little pathways that are going to take us to the next node that we're going to encounter. And that next node that we would encounter is going to be what's called the atrioventricular node. So you have the atrioventricular node, uh, and that's so sinoatrial node, the SA node is your pacemaker of the heart. The atrioventricular node is nicknamed the backup pacemaker of the heart. So if the SA node were to fail to fire, then the AV node could hopefully be responsible for pacing the heart. SA node, remember, fires at a rate of 60 to 100 beats per minute, while the AV node fires at a rate of 40 to 60 beats per minute. So from there, we're going to go through what's called the bundle of His. That bundle of His, we're going to have a branching, if you will. So there's going to be a left bundle branch and a right bundle branch that's going to split off from these bundle branches. So you've got, so going SA node, AV node, bundle of His, left bundle branch going to the left ventricle, right bundle branch going to the right ventricles. And then from there, there are going to be these little finger-like projections that begin to go up into the myocard or the myocardium or the ventricular walls. So we're coming off of the right left bundle branch, these finger-like projections that'll go up into the myocardium. Those finger-like projections are called your Purkinje fibers. Those Purkinje fibers fire at a rate of about 20 to 40 beats per minute. So ultimately, um, if those are the only things that you have fired, you may find that you're in like complete heart block or something of that nature. This is not going to be a rhythm interpretation, not a rhythm interpretation video. I may talk about a couple things in reference to that, but I'll do another video on rhythm interpretation when we get to that point in class. Uh, but it is important to understand that we have an electrical current that runs through the body, and you've got the electrical current pretty much runs this direction toward the apex, and then when we get to those Purkinje fibers, some of that electrical current may kind of go away. That'll be important. Again, no, I'm not going to touch too much on rhythm interpretation, but that'll be important for making sure that you understand why some of your ECGs that you look at may be right side up, or some of them may have a negative deflection looking like they're upside down. So when we talk about this wave of depolarization, or the movement of electricity, if you will, the direction of that wave of depolarization when we talk about a 12 lead ECG or ECG leads in general, the electrodes, if it moves toward the positive component of that electrode, you're going to get an upright deflection of that QRS complex. If it moves away, then you would get a negative deflection. Again, we'll cover all of that when we get to rhythm interpretation. We'll go over that again in detail. Right now, we want to kind of focus just on the electrophysiology of the heart. You know that you've got different electrolytes involved. You have to have calcium that's available. For muscle contraction to occur, and we get this electrical stimulus coming from this electrical current that goes through the body. So the SA node, again, 60 to 100 beats per minute. The AV node, 40 to 60 beats per minute. Your Purkinje fibers are going to be roughly 20 to 40 beats per minute. So we hope that all of our electrical activity originates from that sinoatrial node, and we'll be able to determine that when we look at our ECG. So right quickly, when we're talking about the electrical pathways, let me swap colors here, and I will try my best to draw one ECG with a P wave, Q wave, R wave, S wave, and T wave. So if I do this here, and you'll have to forgive me because I'm not the best artist, but we start with an isoelectric line. We'll give a little bump there for our P wave. Then we have our Q wave, R wave. That's terrible. I'm not doing a good job drawing, but nonetheless, you uh, can get the gist. Then you're going to have your S wave followed by the T wave. So the importance thing to keep in mind is the P wave is atrial depolarization. So this is our P wave. Our P wave is here. Our Q wave is here at the bottom of this triangular looking shape here. The very top of that is our R wave. At the bottom of this is our S wave. Anytime you have two or more waves together, it produces what's called a complex. So this is our QRS complex. That's indicative of ventricular depolarization. So it depolarizes. We also have the T wave. The T wave is indicative of ventricular repolarization. So if something depolarizes, it has to repolarize. So the P wave is atrial depolarization. Now, notice I didn't say that any of those waves were indicative of atrial repolarization. We know that it occurs, but it's obscured by the QRS complex. So after it depolarizes, before the next time that you see another P wave, it will have repolarized, and it repolarizes sometime in this area, but not really denoted by a specific wave on the ECG, as opposed to where the QRS complex is ventricular depolarization, and then the T wave, which follows that QRS complex, is ventricular repolarization. So one way that I explained this yesterday was essentially when you look at the word depolarize, you can look at it as like charge. So we charge our phone every night. So when that phone is hooked up to a charger, we're repolarizing that phone. We're recharging that phone. And then throughout the day, that phone's going to depolarize, lose its charge until the next time we hook the cable into it and it begins to recharge or repolarize for the. So that's one way that you can kind of look at it. But as far as the heart is concerned, this depolarization or repolarization occurs very quickly, because if we have a heart rate of 60 to 100 beats per minute, and some people are on the tachycardic side, some people on the bradycardic side, but nonetheless, whether your heart rate's 50, 80, or 120, this depolarization, repolarization, depolarization, repolarization is occurring pretty rapidly and multiple times throughout the day. And we're lucky that the heart has the ability to do that, the automaticity that we don't have to think about it. It just happens. You've got different innervation, whether it's sympathetic nervous system or the parasympathetic nervous system. We know that stimulation of the sympathetic nervous system is going to tend to ramp up cardiac activity, as opposed to where stimulation of your parasympathetic nervous system would tend to slow down that cardiac activity. But the thing that I wanted to kind of focus on here is to make you understand or appreciate that there is electrical activity of the heart and there's mechanical activity of the heart. The video that I did on the blood flow through the heart talks very much so about the mechanical activity of the heart. We have now what we're seeing is the electrical activity of the heart, the depolarization and the repolarization that occurs. And I want you also to understand that depolarization is not really a synonymous term with contraction. In order for atrial and ventricular contraction to occur, you must have the depolarization, the electrical activity that would precede that. So electrical activity Atrial depolarization, whether it's a matter of milliseconds or not, atrial depolarization precedes atrial contraction. Ventricular depolarization precedes ventricular contraction. A lot of, and I'm not going to say that it's wrong to call them the same thing, but I do think it's important to note the difference. And I'll share a story with you, if you don't mind entertaining. My grandfather, back in 2006, that's when I became a registered respiratory therapist. I was working in the hospital, and unfortunately, he had gotten a urinary tract infection. He ended up in the ICU, was intubated. They did a bronchi. But long story short, he passed away in the ICU. Uh, and I can remember they come in, and they pronounced him that they had the stethoscope, and they listened to his chest and so forth, and they said but much to some confusion in the room, you look up at the cardiac monitor, and there was an organized rhythm. Uh, so in his heart rate, I think was right at 70, maybe plus or minus a couple beats, but the heart rate at 70, you've got your P wave, your QRS, T wave, and this and that, and so it's rolling. But they're saying that he's dead. So my grandfather had a pacemaker placed, and that pacemaker was set to fire at a rate of approximately 70 beats per minute. So ultimately, they did have to, utilize the magnet, stop the pacemaker and what have you, because this was a time before we went to the electronic medical record and so forth, where you still had to, like, if you were going to pronounce somebody dead, it would be frowned upon to you say that they're dead, and you're putting in what looks like a normal sinus rhythm with a rate of 70, printed off in your 6 second strip uh, in the chart. So they did eventually have to stop the pacemaker to do that. So to show that there was true asystole for the 6 seconds or what have you that you're putting in there. But nonetheless, the fact that you are not hearing any lub dub, lub dub, lub dub, lub dub when you palpate a carotid pulse, when you palpate the radial pulse, when you were palpating the femoral pulse, there was nothing, no sounds, no heartbeat, because there was no mechanical event occurring with his heart at that time. However, the electrical circuit, it was wired by the pacemaker at the time, it was still firing. So yes, we were still having those complexes showing up on the monitor. So there was ultimately, when you get into rhythm interpretation, what he was in at that point was PEA, pulseless electrical activity. You'll go through, when you get into ACLS PALS and stuff like that, you'll go over your H's and your T's, the things that could potentially lead up to a PEA type environment. Uh, but I want you to understand that by means of the ECG, well, he was demonstrating atrial depolarization. He was demonstrating ventricular depolarization, but there was no mechanical event that got captured beyond that. Uh, and I should have pulled it up beforehand, but you can pull up uh, the cardiac cycle. So you can look at the Lewis diagram, or it's also called the Wiggers diagram. You can look at that, and if you basically what it does, it puts your jugular venous pressure, your aortic pressure, arterial pressure, ECG, heart sounds, and it pretty much lines everything up right on top of that. So if you'll look at the P wave, and if you can even use a level if you have to make sure that you've got a straight line, where you see that first bump in atrial pressure, you'll notice that it is not directly above the P wave, because there is a slight bit of time after the atria depolarize before the mechanical event occurs. So there is a difference in depolarization and contraction. Depolarization should lead to contraction, but if you have depolarization, doesn't mean there is going to be contraction. So ultimately, they need to coexist. You can have electrical activity without mechanical activity. Pretty much the only way you're going to have mechanical activity without the electrical activity is during basic life support, or you're doing cardiopulmonary resuscitation, and doing actual chest compressions on the patient's chest. And we'll cover more in class when we get down to our action potentials and stuff like that, when we get in there. But I just wanted to kind of briefly go over the electrical circuit, if you will, how it provides its electrical stimulus to the atria, how it provides electrical stimulus to the ventricles, and then also talk about that one heartbeat of a PQRS T wave, all that put together, and kind of talk about the components of that. What is depolarization? What is repolarization? And how that goes about. And then, this will be important information too to kind of understand. You take in the blood flow that we did um, in the other video, take into account the electrical component, and that'll help you understand, like, if you get into some funky rhythms where you're in atrial fibrillation or ventricular fibrillation. So I did this in the other video. My right hand is the atria, the left hand is the ventricles. When they contract, they should contract in a coordinated fashion. So lub dub, lub dub, lub dub, lub dub, lub dub. If you get into atrial fibrillation, that is something you can live with. You may be symptomatic with it, but we want to think about, so the atria are basically just quivering while the ventricles are still able to contract, and that would hopefully help you maintain your cardiac output, or well enough cardiac output to be able to live. Like I said, it may be asymptomatic, it may be symptomatic. Uh, and you may work in a facility that allows you to be at the head of the bed when you go to the EP lab or the electrophysiology lab, to be there to provide ventilatory support when they decide to cardiovert that patient, to try to help shock them out of that atrial fibrillation. So you can live with atrial fibrillation, but if you get into a situation where you have ventricular fibrillation, where the ventricles are quivering, uh, there's essentially not going to be able to generate a coordinated enough contraction to generate any type of cardiac output. So when for patients in ventricular fibrillation, you are going to have zero pulse with that. So that's where the unsynchronized defibrillation comes into play, where the jolt of electricity hopefully helps shock the heart out of that rhythm and get you back into an organized rhythm, so to speak. But uh, again, not a rhythm interpretation video. We'll talk about that a little bit later on. But I did want to cover the very basics of the electrophysiology of the heart, talk about some of the terminology with there, and hopefully it made pretty good sense, and share the story that I'd seen with you with that. When we do get to rhythm interpretation, in order to call something PEA, you will need to feel for a pulse. Another brief story: I was in the ICU doing a patient ventilator assessment one day, cardiac monitor, and I had just gone through, did the Glasgow combs, because I was in the morning. It was time to do the wean and screen. The patient had squeezed my fingers for me. They were able to lift their head off the pillow, but they subsequently closed their eyes back, and the cardiac monitor alarmed, and the nurse from the other side of the ICU comes running in there saying it's PA, pretty much like body checks me out of the way, jumps in the bed and starts to do chest compression. And this dude's eyes just like open up, and he's like, "What's going on?" So, you, yes, PEA happens with patients, but to call it PEA, you probably need to physically feel for a pulse. You know what I'm saying? Now, VFib, if someone's in ventricular fibrillation, you're not necessarily going to call that PEA. That is VFib, and you understand that there's no pulse that happens. But that's a code blue situation. If it's true PEA, then that's also going to be a code blue situation. You've got different algorithms, but we'll cover ACLS and PALS a little bit later on as we go through things. Thank you all for your time and attention. I hope you have a good day.